Good evening. As they say, is this on? Hello, Chris. I see you in the back peeking through the shades. My name is Tim Gibbs. I'm the Executive Director of the Delaware Academy of Medicine and the Delaware Public Health Association. Delighted to welcome you to the first in the Mini Medical School series for this year. What is Mini Medical School? As you know, it's going to be 6 weeks, 2 hours a night. You're going to learn about important health and medical issues. There are no tests. I know the high school students are very glad about that. It's going to help the high school and undergrad students think about whether you'd like a career in the health sciences, or perhaps that this is not for you, and that's equally valuable. For the middle and high school students only, if you attend all 6 sessions, you will be eligible for your choice of either an Apple Watch or an iPad, and we'll figure that out at the very end. In other words, show up, have your seats. Now I'm looking at you. I know you're going to be a troublemaker. For everyone, it's a chance to learn and to interact with healthcare professionals in a non-clinical setting. For most of us, when we go to see the doctor, it involves a shot or some unpleasantness. This time, you get to have the good stuff. So this year's curriculum opens up this evening with treating opioid addiction, goes on to the benefits of cardiac rehabilitation and secondary prevention, and then epilepsy, the latest advances in treatment and care, diabetes, yesterday and today, trauma care in 2018, a decade of progress and beyond, and finally, weight loss surgery, an introduction to the current options and the outcomes with the obesity epidemic that we currently face in the United States and globally. This is a very important topic. Couple of ground rules for everyone, and in particular high school students. If you want to have your electronic device, your mobile device out, go for it. If you want to take a picture and post it on social media, that's fine. If you want to look up a word, that's fine. If I see you Snapchatting, there's going to be a problem. There will be time for questions and answers at the end of the presentation, not during it. And there will be a short break about halfway through the evening. Not all presentations are going to go all the way until about 8:50. And somebody asked the question about the parking garage, says it closes at 9. That is correct. We will be out in time for you to get to your car if you're in the parking garage. We'll be in the Q&A section. If you are concerned that you won't be able to make it in time, feel free to get up and leave. You know where the food is. I see it's disappearing very quickly, as always. You know where the bathrooms are. If you don't, they're out through those doors and then back there, both the men's and the women's. And that leads us now to today's speaker, who is going to be talking about treating opioid addiction. That was the strangest thing I've ever seen. I didn't do that. Wow. Anyway, so this evening's professor is Erin Booker. Erin is the Corporate Director of Behavioral Health for Christianacare Health System. She received her Master's of Science focused in mental health counseling from Nova Eastern University. Erin is skilled in addictions, trauma, grief counseling, mindfulness, adolescent therapy, and crisis intervention. She is credentialed as a licensed professional counselor and will be talking to us this evening about the treatment of opioid addiction. Please join me in welcoming Erin Booker.
Thank you.
Have fun.
Thanks. Hi, everybody. So I have a PowerPoint. I'm going to do my best to use it at some point, but I tend to be just a talker, so I hope you'll kind of bear with me as we go through this. So I'm delighted to be here. This is a topic that is very near and dear to my heart. I think that if you guys sit quietly for a minute and think about who you know who's been impacted by addiction, I'm not sure there would be anyone in this room who couldn't identify one person in their world that has been impacted by this disease. And so that's super important to understand, because we have this idea that addiction hits a certain segment of our population, and that is just absolutely inaccurate. As you'll see from my talk with you guys, we are seeing it everywhere. We are seeing it in every age range. We are seeing it in every nationality. And I want to point out that, yes, we are going to spend a lot of time tonight talking about the opioid epidemic, but that is not the only epidemic that our country is facing when it comes to addiction. There are far more addictions going on. This one is horrific, and it is killing people at a faster and faster rate. You'll see some statistics, and I'll give you some updated statistics as we go through. But we're seeing a rise right now in methamphetamine use. So, talking with my colleagues in other states, they're starting to see the use of opioids go down and the use of methamphetamine begin to rise again. Cocaine, alcohol is still the most abused drug out there. So I want to be sure that we understand that, yes, we're going to focus our time tonight on opioids. However, that is one of many. So please take what we're talking about tonight and understand the breadth of what our country and the entire world is facing, because certainly it's not just stemmed within the United States. But I want to start by really helping people to understand who I am, where I come from, why this is something that I spend every single day fighting. I'm in recovery myself. I have 17 years clean from opioid addiction. I was 15 years old when I started using opioids. So for all my high school friends sitting out there, I bet you can think about someone you know in your school who's using pills or using heroin. And that's really scary for us moms and dads out there or grandparents out there to know that. But I was one of those kids. And I share that not because it's something I'm super proud of, but I share it because I also want you to understand there's hope, that recovery exists, that people can get help and can move forward with their life. I have a lot of clean time, and I'm sitting in a position where I run behavioral health for an entire hospital system. And I was literally told I'd be nothing, that I would amount to nothing and I wouldn't survive. So I want to encourage people to take a different viewpoint. Please take your blinders off as we talk about this and understand that opioid addiction in specific actually is mostly found in middle-aged Caucasians. That's where you're going to see the highest number. That's where you'll see the highest number of deaths. We have a lot of work going on here at Christiana, and we're going to talk some about that. We're going to go over some other stuff, but we're doing a lot of work here at Christiana to fight the opioid epidemic in every way we can, working with our partners in the community, doing some training and teaching to other states, and really starting to partner now with the other hospital systems in the state to say, here's what we're doing, can we help you to do the same? So we're all doing something. So when someone walks into our doors, we can help them. They're not just going to come in and feel judged and turned away and leave care. And that's super important for us. So we're going to talk some about what we do, but I'm going to talk more globally so you guys understand what the breadth of this really is. So there's my overview. We're going to come back to Susan, but I want you to think about this. A 64-year-old grandmother who our nurses start to see some signs that maybe something's not okay. Maybe there's something else going on. And we're going to call in our peer counselors. So we have this awesome program here called Project Engage, where we actually have peers in recovery that work in our hospital with us, and they go out and see patients in their rooms if they're identified as having an addiction, so we can try to help engage them into care and get them placed right where they need to be, so we reach them at that moment where they're willing. So we believe that the hospital is a reachable moment. We have a captive audience, right? They're here, they're in crisis, and that's usually when addicts are the most willing to ask for help or accept help when it's offered. So we're going to come back to Susan towards the end, but I want you to just kind of keep her in your mind as we go through this. So opioids, I'm sure everyone has heard of Percocets, people have heard of heroin, morphine. These are all different types of opioids. And here's just kind of a list of some of the things that, you'll see them used for pain. They'll cause euphoria for people. Dependence and withdrawal occur with repeated use. So this is truly a drug class that changes the makeup of your brain. It genuinely changes how your brain functions. So if we do scans of your brain, it looks different than the brain of someone who's never used. So that's really important. And dependence is different than addiction, and I want to be clear about that. Dependence means your body is physically dependent. Addiction is when you start having maladaptive behaviors that go along with that. So you start breaking laws, you're stealing, you're lying, you're doing things that are not part of your normal character in order to get the drug. All right? This is just some quick information. They used to literally use heroin as, it was just sold. It was just a normal part of a pharmacy back a long, long, long time ago. People didn't understand what addiction was, so it was used as an analgesic, and it was used for surgeries. So why is it popular? Well, there's a lot of access. There's a lot of access to pills. I had a conversation with a 16-year-old son of one of my colleagues, and he said to me, if you asked me to go get something, I could walk around the corner. I know exactly where to go and who to ask. So the access is easy. My oldest child is in 4th grade, and he's heard kids talking about drugs already in 4th grade. So thank goodness I'm a more aware parent about this, so I talk about it. So he's heard it from me first. But there's a lot of access. Kids are finding it easily. Heroin itself is not difficult to find. The effect for the beginning is something they find to be positive. We don't start using and keep using because it's awful the first time that you try it. So there's a positive effect. And honestly, when you're taking a Percocet, the unfortunate truth is people perceive that as to not be harmful because doctors give it, right? So you go, you've hurt your back, or you're an athlete and you get hurt, and they give you pain medication when you are healing. And for some of us, it's an immediate trigger to our biology. And just for some of us, it's a means of escape. But it doesn't feel like you're doing something wrong because the doctor gave it to you. So that perceived harm is a really important aspect of this. So I want to make sure that we're really thinking about that piece of it as you move forward. And just as you go in your day-to-day life, we're doing a lot of work at Christiana just on our prescribing habits and making sure that we're being really vigilant in our prescribing so that we're being safe as far as that. So more exposure equals more addiction, bottom line. The more we put out there, the more people that will become addicted. So as I said, addiction is an acquired brain disease. I want to be very clear on that. This is a disease. This is not a moral defect. These addicts are not bad people. They don't love drugs more than they love anything else. This is a brain disease. And it's really important that people understand that, because that's how it needs to be treated. We will not be successful in treating addiction if we're treating it as a moral defect, because people will feel judged, they won't show up to care, and so we won't have an opportunity to even help them. So it's really important to understand that this really is a disease. Again, repeated drug use is in vulnerable patients. There's reward and motivational circuits that become involved. You have physical implications if you do not use opioids once your body has become accustomed to having them in its system. So if you've ever had the flu, it's really awful, right? Yeah, it's not fun. I've had the flu, it's really bad. I've also been in opioid withdrawal. It's really bad, and it's scary, and it's overwhelming, and people will do whatever it takes to not feel that way. So if you talk to someone who's been using for a while, they'll tell you, I'm not trying to get high, I'm just trying to stay well. They're not chasing a high anymore, they're just sick. And you'll see that. So it's important to understand that that's real, that there is a change in your body's chemistry with continued opioid use. So again, with dependence, your brain becomes maladapted, and you will literally go into what we call primal misery. That is the term that we use for withdrawal. I see people taking notes, so I don't want to move too fast. But it's really important. Not getting sick is a very highly motivating reason to keep using. So in 1996, there was a release of extended release oxycodone. We saw a huge spike in addiction at that point. There has been a lot of work around this. There's a lot of standards of care for requiring assessment and treatment of pain, because giving out pain medication too easily is dangerous. So you'll see, we have things called accreditation as a hospital system. We have people that come in and monitor us and make sure we're doing what we're supposed to do to take care of everyone who comes in our doors. One of the things they're checking is, are we assessing pain? Is there documented assessment of pain before any medication is given? And then are we going back to the patient and reassessing later to make sure that the medication is working the way it's supposed to? So increase access to opioids through more prescribing. You'll see here something called pill mills. Those are actively happening in our community right now. Those of us who work in substance abuse treatment, we know the names of providers that when I hear a certain name, I'm like, oh, that's dangerous. There's a risk there. People are going in and paying cash. There's a lot of unfortunate bad medicine being done. We've recently seen someone in Pennsylvania be arrested, a doctor, and he'll spend some time in prison for his actions with the prescribing of opioids. So this is happening. I want you to be mindful of that. Pills have a less perceived harm. There's not as much of a stigma. There's this idea of, well, at least I don't put a needle in my arm. You're dying just the same. No different. And that's really important to understand. There's no difference between someone who's using heroin and someone who's taking a Percocet. And so, but there is a perception that you're not as bad. And even in addict culture, there is a perception within, they class themselves. Well, I'm not as bad as that person because that person's doing this and I don't do that. And my answer is always, you don't do that yet. Because as you continue down this path, you will. Everything you say you won't do, you will, until you either get clean or get buried. And that is the reality of a drug addict's life. And that's really, it's scary. It's, for any of you out here who have someone that you know and love that is fighting this disease right now, it's scary because you're watching them slowly commit suicide. And that's what we tell people. This isn't a game. This isn't a playtime in high school to have a fun time and get high for a little while. People are dying very rapidly. And we're going to talk more about that and the numbers that we're currently seeing. So this is just a story that you could see in a town in Mexico. People were selling heroin outside in public like they were selling pizza. Just not hidden, not concerned, just walking right up to people. So these are some trends in deaths. So the supply, because we've got a lot of new laws. So prescription monitoring is happening. And it's effective, which is awesome, except for what we're seeing now is more people are using heroin because they can't get pills. So their addiction didn't go away. So we did a great job in placing laws, and I applaud lawmakers for even recognizing the need to do this. And I applaud the doctors that I work with every single day for being vigilant and mindful of this. But where we fail often is that we didn't come up on the back end and make more treatment available. We didn't put more engagement work out there. We didn't do more outreach. We cut the ability for people to get pills, and we increased the use of heroin. And that is the honest truth of what we're facing now. So heroin is cheaper, it's easy to get, it's easier to inject. Heroin is purer than it's ever been. And again, now it's becoming more and more acceptable. Young adults using, you can't really see this very well, but on the top there, one of the things it says is prescription opioid use disorder and heroin use among 12 to 34-year-olds. 12. As a treatment provider who has spent the majority of my career before I went into administration with boots on the ground, seeing patients, working in rehabs, I have treated many, many people who started using at the age of 10, 11, and 12, who started using with their older sibling, who started using with their parents. This is a familial disease very often, so you will see generational addiction going on. And sometimes it will be just one person, but they're starting younger and younger and younger, so it's really important to pay attention to that, because we're going to talk a lot about some medication-assisted treatment interventions, but many of those are not allowed to be used with kids under 18. So you're talking about a 12-year-old, or a 14-year-old, or a 15-year-old, who's fighting a disease that they don't know how to fight, and parents, quite frankly, are often too scared to have the conversation. So I just wanted to really emphasize that we're seeing 9 times increase in the use of opioids with young adults. That's huge. We're also seeing an increase in fentanyl. I'm sure you've all heard that on the news. Fentanyl is another form of opioids. It's now being mixed into heroin, and people are dying faster and faster because it's far more potent. So it doesn't require as much to get the high that you're trying to get. So they don't know that it's mixed into their heroin. So they use the same amount they normally do, and then they die. Or they overdose, and they're with a bunch of people who are too scared to call for help. I know people personally whose children have passed away of this disease, whose friends dropped them off in a parking lot of a hospital but were too scared to go inside. And their child died in the parking lot. But this is happening without their knowledge. They're not going saying, give me the fentanyl. But it's being mixed in, and it's a huge problem right now. It's causing things like Narcan, which we'll talk about, which is a life-saving medication. We're having to use more of it to save people because the amount of opioids in their system is so much higher because of this. So there's a lot of warnings. I always like to point out the mixture of opioids and benzodiazepines because that is a scary, scary mix for those of us that work in this field. So if anyone doesn't know what a benzo is, it's something like Xanax or Klonopin, sorry. These two medication classes mixed together can stop you from breathing. It lowers your respiratory rate to such a high extent that you just stop breathing. And we've actually seen people, those of us who have done this, who've been walking and just collapsed. So that's a mix that's really dangerous, and so we're always paying attention to that. That's kind of our secondary focus in our system, is not just who's taking opioids, but who's got opioids and benzodiazepines on board, because we have to be really, really vigilant with those patients. All right. These are just some age-adjusted rates of death related to prescription and heroin. And basically, you'll see the number of overdoses are going up. We're not trending down, you guys. We're trending up. There's a lot of education. We've seen how bad it is, but the number of deaths are rising. So you can see the deaths across our country and how much more red there is, right? So in 2003, there were spots, certainly, that were being really negatively impacted. But take a look at 2014, where you see that orange and red color. That's where the highest amount of overdoses are happening, and that is spreading. So again, this is not a geographical specific addiction. This is not a class or socioeconomic status specific addiction. It is an equal opportunity death sentence if you find your way down this path. So increase in drug and opioid involved overdose deaths in the United States. Again, we're just clearly saying that we went up from 12.3 per 100,000 in 2010 to 16.3 in 2015. It's higher now. And our goal every day is to come in here and save the lives of anyone who walks in the door. We want to start seeing that trend down. So we're working across state lines. We're working throughout the state so that we're all partnering together. This isn't Christiana Care's initiative. This is the state of Delaware's initiative, because we want to save the lives of the residents of our state. We just had West Virginia here because in one day they had 17 overdoses in one county, one tiny little county, 17 people, and they saved every single life. Not one person passed away that day, but not one person went to treatment either. So we're working with them to get that next layer in, like we do. When someone overdoses, we then work to get them into treatment if they're willing. I'm just gonna bring them all up. Oh, sorry guys. So in Delaware, we have, this is some older data from 2005. It's hard to get more recent census stuff sometimes, but 900,000 people. Out of that, 90,000 people in our state are alcohol or drug disordered, which means 90,000 people are using drugs or alcohol inappropriately. 9,000 are opioid dependent. That number is wrong. I'm just going to tell you that right now. It is far higher than that now. But the next number is super important. 10% of people go to treatment. 10. And that's not the number of people who are successful in treatment. That's the people who are brave enough to walk through the door. And I want to be clear about that because it is brave to walk through the door. It is brave to say, I'm in trouble, I need help. Please, if you know anyone, it's not shameful. They shouldn't be embarrassed. They should be really proud to walk through that door and say, I need help and I don't want to die out there. I think we get scared. People get scared. I used to have patients walk into rehab and I'd seen them pull into my driveway of my treatment center and pull out like 6 times before they got the courage to get out of their car and walk through the door. Some people drive there for a week or 2 before they have the courage to get out of the car. But as a community, we support people and say, we encourage you to go. We'll help you to get there. Don't be embarrassed. The lives we could save is pretty amazing. So this is some information from the Delaware Drug Monitoring Initiative. This is older information, so I want to correct some of this. So what you're seeing is that Newcastle County is at the highest rate of overdose fatalities. We still are, without question, except for the numbers are much higher. So we're now, last year we had over 300 deaths in the state from opioid overdose, and we're on track, unfortunately, this year to be even higher than we were last. And we're not that far into the year. So, and Newcastle County still is the predominant, but we are seeing it go up more and more in Kent and Sussex. One of the things that I have the displeasure and pleasure to be a part of is that the state has an overdose fatality committee. It's a commission that Matt Den put together. Our chief of addiction medicine, Dr. Terry Horton here, is the chair of that. And our goal is to understand from those people who tragically lost their lives to this disease, what can we learn? Where were there reachable moments that we missed? What can we do differently as a system so that we save the next person? So I have the unfortunate pleasure of being the chair of the Newcastle County Review Team. So I review the death record of every single person who passes away in Newcastle County of an opioid overdose. I read through their medical records. I follow their journey to see what we can do differently. In 1 month, I had 11 charts to review just from our county. In 1 month. That's frightening. That's 11 families who lost someone they love. And I want, this is becoming more of a cause of death than motor vehicle accidents. You know, we're unfortunately taking over the role of all sorts of different ways people pass away, and we're at the top of the list. So I want to point that out. So you see 29% heroin, that's no longer the case. What we're seeing now is that that's more like 57% is straight heroin, but more than 80% of overdose deaths is polypharmacy, which means they have more than one drug class in their system when they pass away. Okay, so it might be the benzos and opioids, it could be cocaine and opioids, it could be alcohol and opioids, but they're finding more drugs than just one in the people's system. So that's really important. The number of people that had prescription drugs in their system, that number is going down while the heroin number is going up. So one of the things that's really important is helping to make sure that prescribers understand the risk and they're paying attention to those risks and they're paying attention to the risk factors as they're treating patients. That's really important for them to slow down, take some time to really know their patient, understand if something feels uncomfortable or feels off. One of the things that I know is that as a doctor, it's really scary to say to someone, do you have a problem with addiction? Because when they say yes, you don't know what to do to help them. And one thing I know about doctors is that they don't like to not be able to help. It's not comfortable for them. It frightens them. They are built to help people. That's why they're doctors. So we've been able to walk in and say, ask the questions, we're going to come in and we're going to help connect them to care. We're going to help steer them where they need to be. So don't be afraid to ask the question because we can help you navigate. That's been huge for the doctors. And so really doing a lot of education is incredibly important. Obviously, one of the ways we tackle is we reduce inappropriate access, increase access to effective overdose treatment. And we're going to talk more about that, but that's really important. There is treatment for overdose. If someone is overdosing, that is not necessarily their death. There are ways to help them in that moment. Obviously, we want to provide substance abuse treatment to persons that are addicted. And we want people to understand what the resources are, if people need help, how to ask for it, who to reach out to, what to do. Prevention is super important. I don't know, there's a wide range of age, but I grew up in the age of DARE. And the DARE program, which is now known to be harmful. It was a great idea, but it's now known to have been harmful. But how many people have seen or remember the commercials with the eggs cracking, saying this is your brain on drugs? Those worked. You want to know why those worked? Because it didn't vilify the person. It didn't make them feel bad about who they were, or if they knew someone who was an addict, it didn't make that person a bad person. It made the drug the bad thing. DARE made people bad. That person over there, you're going to end up like that. You're going to be one of those people. Well, I've treated everything from CEOs to doctors to lawyers. Those people are everyone. So as we're talking about prevention, we want people to understand that it's about helping anyone understand the problem with the drug, not the problem with the person, because they are not the problem. So we want to reduce access. We do that through responsible prescribing. We want people to understand how harmful this is. You will hear us talk often about, and I purposely make it very clear that this, you will die. I don't sugarcoat it, and I don't sugarcoat it for a reason, because when we think that we have an opportunity to do this and be okay, it makes it easier to rationalize why you should do it. And you might be okay today, and you might be okay tomorrow, but you can't guarantee it ever. And that is really important to understand. So we want people to understand the harm of this. So we need to increase how people view that. So Narcan, this is what I've been talking about. Narcan is the most effective way to reverse an overdose. We are really lucky in the state of Delaware because you can go into the pharmacy and buy this. You can keep this in your home. If you have a child or a sibling or a significant other who has an addiction problem, this can be in your house. You can be taught how to administer it, and you can have access to it. It's nasal spray. Yes, there's injectable Narcan that paramedics can use, but this is a nasal spray. Our police officers throughout most of the state are carrying this. Clearly, paramedics and EMTs have this. Firefighters have this on board. We are keeping this active, and we are seeing, I just from Newcastle County EMS in the months of December and January, there were 190 Narcan utilizations in Newcastle County. So in 2 months, so 62 days. 190 people, and that does not include St. Francis's EMS. I'm waiting for their data right now. So just from the Newcastle County Ambulance and Police Department, 190 times Narcan was used in a 2-month period. That's 190 people who might not have lived if that wasn't done. So it's a scary number, but I'm so grateful for it, because that's 190 families who didn't have to start making funeral arrangements. And that's 190 people that we have the opportunity to now say, you're worth it, we're here, let us help you. Narcan is what gives us the ability to do that. So there's trainings, there's a lot of education around for that. So this is Narcan use. You'll see that the use of Narcan has gone up. This is by age. Narcan use is mostly seen in the young adult population, as you see. So you're seeing that rise in that 25 to 29 and then moving into the early 30s. So treatments. There's all different treatment options, and I think that's important to understand. So outpatient, pretty self-explanatory. You live at home, you go into treatment. Depending on your severity and what we, as clinicians, what we assess you to need, will tell you how many times a week you're gonna come in and see us. Inpatient is, rehab. So the cliche of 28 days, unfortunately, does not exist any longer in our world. Unfortunately, we all live in the land of managed care that manages how long you stay in treatment. So unless you're a self-pay, we've now learned to gear treatment to 15 days or so, which is sad. And for all of us clinicians, it is a battle we fight daily. There's drug-free treatment, which means you're not on medication-assisted treatment. You're going to group therapy, you're seeing an individual therapist, and you're working through that. You might be involved in the 12-step fellowship, so AA, NA. There's Cocaine Anonymous. There's all sorts of anonymouses now. There's Marijuana Anonymous. So there's something out there for everyone who's struggling. Medication-assisted treatment. I'll be very honest, for opioid use disorder, medication-assisted treatment is research as evidence-based treatment. It is the most successful treatment option we have in our playbook right now. So that's methadone, that's Suboxone, that's Vivitrol, for anyone who knows anything about those. Suboxone is a medication that private doctors can take a specialized training and be able to prescribe. So you might go into the office once a week. You might go into the office once every 2 weeks as you start to improve in your treatment and in your recovery. Methadone, we've heard of the methadone clinics. It gets a really stigmatized thought process, but a lot of people are alive because they get their methadone every day. And so I'm really grateful for the methadone clinics and the people who work there, because there's a lot of people who you would have no idea are taking methadone every day. They're functioning, they're working, they're part of society, and they're doing really well, and this is what keeps them doing well, and so that's okay. That's their recovery. We struggle in the 12-step fellowship because people get really stuck on medication-assisted treatment and start saying that people aren't clean because they're taking another drug. We don't view it that way. They're taking medication as prescribed by a physician for a disease. I wouldn't tell someone who's diabetic that they're doing something wrong by taking their insulin. I wouldn't tell someone who has high blood pressure not to take their meds. I wouldn't tell someone who has bipolar not to take their medication. This is a disease no different. And so that's really important. So you'll see the fellowship on here. But medication-assisted treatment, I want to be very clear, there's the word treatment in there, so that means that's not just about handing you a medication and pretending you're fixed. There's a reason that many of us specialize in addiction treatment. There is a huge need for the therapeutic component in care. So it's not just about handing you a medication and saying, this is going to save you, but it's about helping you to understand what is going on, where do you need to heal, so that you can move forward. When I was an active therapist, when people would ask me what I do for a living, my answer was very simple. My job is to heal hearts. Because it's that causes people to continue in active addiction. They are hurt and they are broken, and we have the privilege to help them learn to put themselves back together. So medication-assisted treatment involves that. It is not a quick fix. It is not hand you your dose and see you tomorrow. That's not real treatment. Real treatment involves therapy, group therapy, individual therapy, family therapy, couples therapy, whatever it takes for you to have what you need to be successful. So these are FDA-approved anti-opioid agents. So these are different types of medications, like I just said. So Vivitrol is one of the newest. For people who don't know, that is an injection that you get, and you get it every 4 weeks. And what these medications do is that they block the receptors on your brain. So if you take an opioid, it can't attach, so you don't get the effect. Okay, so that's why it works. It's not just haphazard. It covers the same receptor in your brain, and so when that is covered already, if you put heroin in your system, it's got nowhere to go to attach, so you can't get high. So that's why we use these medications. So Vivitrol is a every 4 week intravenous shot. You get an IM shot, you come into the office, and we would do that. This is a harder one to utilize, I'll be really honest, because you have to be off of all opioids for a pretty lengthy period of time before you can get your first injection, so it's a little bit more complex. But it's something that we're working really hard in our state. An agency called Connections that works within the prison system. We're working really hard to help to get permission for inmates before they get released that are opioid addicts to start them on Vivitrol so that they have a chance to stay clean and sober when they come out and really continue to be a positive influence in our communities. So methadone, I don't think I need to read all of this, but methadone has been around the longest. It's been used the most. It's probably the most well-known. It's also the most well-criticized, unfortunately. But It is absolutely saving lives every single day. So, unfortunately, treatment by itself, if you look at this, the blue is the percent of 180 days post-release in treatment. The red is 80 days post-release used heroin. So you see that when it's just counseling, which is that C, we have a really high number of people who 180 days post-release are using again. Counseling plus methadone, we have a much better result of people who are staying clean and sober. So that's just to really emphasize the fact that it's a joint thing. This is not one or the other, they work together. Relapsed intravenous drug use after methadone maintenance treatment for patients who left treatment, 82.1% of people were using again within 10 to 12 months of that 105 patients. This is just some information about buprenorphine. It's, again, a synthetic opioid. It has a ceiling effect. So one of the positives of Suboxone is you can't get high from Suboxone because it has what we call a ceiling effect. So there's no ability for that to happen. So it unfortunately has some street value, but for a fortunate reason, people are using it to try to detox themselves. So they're buying it on the street to try to detox themselves. They're not buying it on the street to try to get high. So the withdrawal is a little bit milder than it would be from methadone. It goes underneath your tongue and it will dissolve. So if you take it somewhere where they where you come into a program and take it, they'll watch you put it under your tongue, make sure it dissolves so that you're getting the full effect of the medication. In case you missed it. So the reason, I want to bring that back up, the reason we have that there in such big letters is because when we started to talk about some of the stuff that we do here at Christiana, and one of the things we do is that we have something called an opioid withdrawal pathway. So we screen every patient that is admitted to a medical floor to see if they're at risk of going into opioid withdrawal, and we're going to talk more about that. But one of the ways we got doctors and the hospitalists that treat patients on the medical units to feel more comfortable with this was to help them understand that it reduces the risk of overdose. That if you let a patient come into the hospital and go into withdrawal, they're going to do one of two things. They're going to leave against medical advice and their medical need is not going to be cared for, or they're going to use drugs in the hospital. We've seen it all the time. Nurses who walk in and someone is shooting drugs in their hospital bed because we weren't caring for their withdrawal. We were pretending. We weren't asking the questions. We didn't know what to do, so we didn't treat it. So we taught doctors that if you do this pathway that we're handing to you, they're not going to get high in the hospital, so they're safe. And that help them to feel more comfortable. So we kind of scream this from the rooftops, that Suboxone blocks other opioids and reduces overdose risk. So this is just some more data that shows that there's a reduction in overdose deaths with the use of medication-assisted treatment. So mortality risk during and after opioids substitution treatment, you have to be mindful that if someone stops going to care, their risk of overdose goes up because their tolerance has gone down. So when I ran a rehab, one of the things that patients were taught as they walked out the door at discharge was, if you make the choice to use again, please don't use the same amount you used when you came in here, because you will be at very high risk of overdose because your body has not had it and it's not as tolerant to it anymore. So that's really important. So we actually teach people that if you're going to make the choice to use, please do it as safely as you can. That feels very uncomfortable, I'm sure, to hear that we educate that. But if we don't, the overdoses were higher. So risk factors for relapse and higher costs among Medicaid members with opioid dependence or abuse. So addicts cost a lot of money to the system. That's why it's always amazing to me that insurance companies don't want to pay for care. Because when they're not in care, they're very costly to the insurance companies. So MAT reduces relapse compared to behavioral health or behavioral treatment alone. So we've talked about that already. This just kind of gives you a nice visual of that. Injectable naltrexone is another form of medication that can be used. So you can see that's some data of research that's been done with that, and there's been some really great results. So those are just a summary of the benefits of medication-assisted treatment. Certainly, you can tell I'm a big supporter. We had a patient's mom say this to Dr. Horton, our chief of addiction medicine: "I don't want my son trading one addiction for another." And my answer is that addiction, again, is different than dependence. Please remember that. Being physically dependent on a medication is different than being addicted. Addicted means you're stealing, you're lying, you're living a life that is against your moral judgment, and you can't stop. Dependence means your body needs it. That's very different. And so we educate families on that. They're not addicted. It's a medication that's helping to keep them alive and functioning and a wonderful member of your family, instead of the person who came to Christmas dinner and you don't know what's going to happen. So, again, I said this before, we think of the hospital as a reachable moment. And so that's super important. The doors are always open. We don't close. People come in every single day, and they come in sick, or they come in having just overdosed, or they come in with abscesses, or they come in with infections in their hearts from IV drug use. And they're here. And so then we have an ability to walk in and say, "How can we help you? Will you let us help you?" There's our wonderful hospital. So we have a little over 1,100 beds. Those are the number of ED visits and admissions that we have in a year, approximately. So prior to 2008, we did no screening at all. People came in. We didn't acknowledge that addiction might be an issue. We treated their medical need for as much time as they were willing to let us, and we moved on with our day. And people got frustrated, and nurses were frustrated because patients were acting out, and they didn't know what to do. So there was no standardized withdrawal treatment. Social work consult for referral, maybe. So this was our reality. So withdrawal occurs with unplanned admissions. If withdrawal is poorly controlled, patients will use. They'll become really demanding of pain meds because they're sick and they're scared. And so they get seen as the problem patient. I will get phone calls that say, "Hey, Erin, can you or someone for your team come up and see this person because they're really being they're being really difficult. They're yelling and screaming at us. We need help." Well, they're sick, and we're ignoring it. Or they'll leave against medical advice. So it's really important that we addressed this as a system, that we had the ability to engage and transition them into community-based drug treatment. We can't do that alone. We do that with our partners. I'm going to pause right here, and we'll come back and talk more about what Christiana is doing if you guys want to take a 5-minute stretch break. And I promise I'm going to get you out before the garage. I'm in there too, so don't worry. I just said I can't get locked in. My kids will be so sad if mommy never comes home tonight. So we are going to be out on time, I promise. All right. So opioid withdrawal is a safety issue. So poorly addressed opioid withdrawal has negative impacts, bottom line. And our ability to address serious health consequences of addiction really does depend on us treating withdrawal. I have watched people with something called endocarditis, which is an infection in your heart, make the choice to leave the hospital because they were sick and they didn't want to be sick, so they left with an infected heart. Endocarditis, if not treated, not only do you possibly end up needing a valve replacement, but if you continue to not treat it, it's deadly. But that's how powerful withdrawal is. So I want to point that out. We can't treat medically if we don't treat withdrawal. Oh, let me not do the wrong thing. So we also know that what we saw, this is a copy of some patient satisfaction data from our lovely hospital system, and red is bad. We were really red for those patients who were diagnosed with an opioid addiction. So this is not, let me disclaimer for Christiana's sake, this is not our normal everyone satisfaction survey. We pulled out the subset of those people diagnosed with opioid addiction. So where do we have green? They felt like people helped them to the bathroom and helped them with that. And that there was some quiet at night. But everything else, they felt like we didn't care. They felt unheard. I wouldn't want to stay here either if that's how I felt. So we showed this. We took this on a traveling road show and we showed providers. This is the feedback. Their voice matters. It's also really, really costly. So for, when you're struggling to get people to understand why they should invest in things like our opioid withdrawal or Project Engage, which makes zero money and costs a lot of money, it's one, and first and foremost, the right thing to do. And two, the cost of patients with addiction is very, very high. We know that what we were seeing before, someone who would come in and need to be here for 6 weeks of antibiotics through IV, that person was a $40,000 loss to the system, that one patient. Because if you think about it, sometimes people go home with things we call PICC lines and they get their IVs at home, they get their antibiotics at home. But we can't send home an opioid addict with a PICC line because we're giving them immediate access to shoot drugs. So we keep them here for their safety so that we can treat them. So this is just showing some rise in ED visits and inpatient stays. Oh, sorry. So drug-related endocarditis, you're seeing this. I want to say, you can look at this data, but just within our walls, we just reran our data. We have over 100% increase in the number of patients that are presenting with endocarditis or spinal abscesses due to IV drug use. We're seeing people come in with noxic brain injuries from overdoses that weren't reversed fast enough, so their brains didn't get oxygen. We're seeing people having strokes. So as I said, we anticipate back, and that's not even current, over 6,000 bed days used to keep patients in the hospital for IV medication treatment so that we know they're safe and getting the medical care they need. Oh, I forgot bone infections. IV drug use causes significant infections within the bone. So in 2016, I joined Christiana Care in 2016 at a really amazing time as an addictions professional, to be sitting in the seat where I run operations for the whole service line, to be able to make decisions to do things like this. And I was lucky enough to work for an organization that was willing to let us do things like this. So in 2016, we partnered with the acute care service line. We decided to begin screening. So as I said in the beginning, every single patient who walks in and gets admitted to a medical floor, there's certain floors that are not part of this, like the ICU, because that's just a different type of treatment regimen. So we're creating their own pathway for them. We're creating a pathway with surgery. But anyone who goes to a medical floor is being screened for opioid addiction. What we're really screening is who's going to go into withdrawal, so that we can be proactive in that and help them to feel supported, safe, and cared for. So we have rapid treatment of withdrawal by the medical team, inpatient initiation of drug abuse treatment. We have now an addiction medicine consult service. That did not exist a year and a half ago. You now can call our addiction medicine team. We've hired 2 more addiction fellowship trained psychiatrists who specialize in addiction. You now have access to picking up the phone as a provider here and calling directly to one of our addiction team members and being helped with how to manage your patient so that they are taken care of properly. And then we have referral to community-based care using Project Engage, which again, Project Engage is a contract that we have with Connections. So it is a partnership. The Project Engage peer engagement specialists work for Connections, and we have contracted to have them within our hospital system. They live within our walls. They walk around with our badge. They are a part of our team, no different than anyone who is an actual employee of Christiana. And when someone is identified on our opioid withdrawal pathway, they are immediately notified so that they can go in and talk with that patient. So again, these are peers who are in recovery themselves, who can help people to understand that they've been there and there's a different way to live. And then we work together. We have a social work team that's dedicated just to Project Engage, and we work to get them connected to care. And we literally will have them discharged from our doors and walk into the door of a treatment facility, whether it's inpatient or outpatient, the day of discharge from us. So there's no break in care. We have a special pathway for pregnant women. So we have worked really hard to partner with our Women and Children service line, and we have created a pathway. So if a pregnant woman comes in and it's identified that she has an addiction to opioids, we immediately engage with them. We also have OBGYNs who are now trained and able to provide a different form of Suboxone called Subutex that is approved for use in pregnant women and safe for the baby. Having done that and this process, we are seeing a decrease in what's called NAS babies. So that's neonatal abstinence syndrome. So it's babies who are born addicted. And we have our own outpatient medication-assisted treatment program where we utilize Suboxone and Vivitrol. So this is part of the clinical pathway. These are the 2 questions. The Value Institute, which is a research leg of Christiana Care, is completing our validation study on these because there was no withdrawal screening that was validated in the country. So we have created it and are validating it ourselves. So these are the questions that everyone's asked. Have you used heroin or prescription pain medications other than what was prescribed in the last week? We asked both questions so they could say no to that. But the next question is, do you get sick if you can't use heroin, methadone, or prescription pain medication? Because what we know is patients are more likely to say yes if you identify that you recognize they'll get sick. Because we're actually showing that we want to do something about them being sick. So Project Engage, again, bedside peer-to-peer intervention. We have peer engagement specialists in both EDs, and we have them in both hospitals for the inpatient setting. So if someone comes into the ED and is identified as being in active addiction, even if they're not admitted, we have someone there that can engage with them and help connect them to care if they're willing. So right now our addiction medicine consult team is one full-time, sorry, my iWatch is yelling at me, a full-time physician and a nurse practitioner. We do not allow nurses or unit clerks or anyone else to put a consult in. It has to be the prescriber. So the doctor or the PA or the NP, because our team wants to educate them in how to care for the patient. So we don't want to talk to the nurse because we want to talk to the person who's going to be caring for the patient and help them to understand what we're going to recommend, why we're going to recommend it, and so that next time they're going to feel more comfortable to do it. So we've actually seen decrease in our number of calls because doctors are feeling more confident in their skills and more willing to do it. And that is awesome. Our joke is that we'd like to go out of business. We'd like to be able to close down the addiction consult team because we've supported our hospitalists well enough that they know how to do this and they believe in it and they care about it and they want to. One of the things that's also really important that I don't believe I have in my slide, sorry, is that we also added a psychologist to the addiction consult team just recently, and she is a trauma specialist and an addiction specialist because we know those go hand in hand. And so now for those patients who are here for 6 weeks, we are actually starting treatment at the bedside. They're getting seen by a psychologist 2 to 3 times a week and really starting to get care so that they're not just sitting in a bed, but we're helping them to heal while they're here. So these were some results that we had after 7 months. We've continued to show some positive results, through some really positive results, quite frankly. We've identified over 300 people with opioid use disorder that were not engaged in care, that came to the hospital for pneumonia or an infection of some other sort, and we were able to identify a need and help. We saw a decrease in our AMA rates of that population because that's a pretty significant drop. Because again, they felt heard, they felt cared about, the feeling of being judged decreased, they weren't sick, and so they stayed. So a lot of people are asking, so we do a 3-day Suboxone detox for those patients on the opioid withdrawal pathway. Many patients are asking to stay on medication-assisted treatment, so we're connecting them to care within the community. So at the time where we collected this data, 62% of patients that we had engaged with had asked. Just some data for you. One of the most important things I want to point out is if you see some of these, 78% went to their initial appointment, 71% were still in care a month later. This is abnormal. This is not, if you research retention rates in treatment, this is not what you'll find. And quite frankly, if you look at retention rates in drug-free treatment, you're going to see single-digit percentages. We've created a system where we do a warm handoff directly to care. We've done the foundation work here, and we're seeing amazing success of people staying in care and their lives changing. We have them come back and visit us. They'll just come in to tell us hi and to say thank you. They'll go on the units and hug their nurses who treated them and say, we have a young guy who's 22 now. He's been here twice with endocarditis, found out that his girlfriend was pregnant during his last stay and finally said, okay, I'll get help. He's now got like 9 months in recovery. He's starting his own business. He's productive. He's an active father. This is the benefit of all of the heartache that we see, is that those patients come back and say thank you, and we see lives changing. So again, 63 remain in medication-assisted treatment at 1 month. So our outcomes are limited by where we can go, right? I can do everything in the world when they walk through my doors, but if I have nowhere to send them, I lose. They lose. And losing in this game is dying. So as a system, we have made a very firm commitment to helping to create partnerships with other community providers. How do we help them to support their programs? How do we help them to grow? We've gone in and provided medical care in some programs in order to help them feel comfortable treating certain populations. We are willing to do whatever it takes to continue to see lives saved. That's the bottom line. We are not going to stand quietly and watch more and more and more of our state die. So just some extra information. Delaware's heroin babies starting life in withdrawal. This is a very real problem. And moms are ashamed, and they don't need people to make them feel bad. So NAS patient days, you see the trend. It was going up and up. It's coming down. We're able to get babies healthier and safer faster and home with their parents, or home with wherever they're going that's safe for them. But it's only because I've never seen anything like this in my life. I have done this work for years. I have OBGYNs who are saying, help me get certified. I want to treat them. I don't want them to feel ashamed. I want them to know they can come here and be cared about. We've created our own office-based opioid treatment so that those patients who have a really high medical issue or comorbidity, we can treat them where other sites are a little more leery of that because of the medical. We're in the hospital. We have an outpatient in Wilmington that we treat and have a substance abuse program. Remember Susan? So our 64-year-old grandma, she came in, got a stent, started showing signs of opioid withdrawal. Denied, denied, denied. Not me, nope, what are you talking about? 64. She talked to our engagement specialist and admitted that she was inhaling 3 to 4 bundles of heroin a day. For those of you who don't know what a bundle is, it's 13 bags. She was doing 3 to 4 a day. A 64-year-old grandmother. If that doesn't wake you up, that this is not a young adult only problem or a lower class problem, $1,800 a month. Just want to be normal. I started this by saying they're not trying to get high, they're trying to stay well. They just don't want to be sick. This 64-year-old just wanted to have a cup of coffee with her husband and not feel the need to go chasing after a drug in the morning. That is powerful. We got her placed on Suboxone. She was scared. She was scared of being stigmatized. But my nurses on the units were amazing. They made her feel so loved, so cared about. They all they wanted to do was take care of her, and she felt it. And so she was willing to get help because she felt like she was worth it, and no one was judging her. But then she no-showed to her discharge follow-up appointment. Her husband was using. She hadn't shared that. She and her husband are in recovery. Because we didn't give up. People relapse. It's a symptom of the disease of addiction. So I want to close by just reminding you guys, addiction impacts everyone. Again, take a minute, think of your life. If you don't know someone who's being impacted by addiction, I will be shocked. But I have unfortunately been personally impacted, and I have buried countless people to this disease. Christiana Care is taking a very strong stance against the opioid epidemic, and we will continue to fight every single day to save lives. Thanks.
That was good. Okay. Oh, there she is. So, Dr. Smith and myself are going to go on either side. You stay over here. Who has questions? Oh, what's the question?
Yeah, two questions. One simple one. Is it the Narcan? Is it effective if someone's already stopped breathing?
So I was asked to repeat questions for videotaping, so if I sound crazy, that's why I'm doing it. So is Narcan still effective if someone is not breathing? Yes, okay. Absolutely. So it's amazing, actually, to watch it work. Literally, someone can be completely down, heartbeat not going. You can give this, it tears the opioids off the receptors, and you'll see them revive.
And the second question, and this may run a little contrary to what you covered tonight, but has there been any research done around people who successfully quit on their own, cold turkey, or whatever? Maybe not to say cold turkey, I know that's not always advised.
Yeah.
But on their own, without any of this.
So the question is, what is there research on people who are able to have recovery without going into a treatment system or medication-assisted treatment? There's some. It's hard to do because they're not engaged in any care, so it's hard to do. It's the anomaly. It's the, I'll be really honest, I am in long-term recovery from opioid addiction, and I was not on medication-assisted treatment, but I am the exception, not the rule. So we don't have a lot of research on people who never engage in care because we just don't know who those people are.
Hi, I'm a senior at Conrad School of Science, but my question was, how much do you think media has impacted the epidemic?
How much do I think media has impacted the epidemic?
Sort of in causing the epidemic.
So do I think it's caused it? I think it's glorified it. Yeah, I think, it's really sad we become desensitized. So, when we talk about that perceived harm, when you're watching movies and people are using, or you're watching music videos and people are using, it looks like it's the fun part of life. They're not showing you the other side. So I think it's glorified it, absolutely. Who will get there first?
Hi, I'm a sophomore at UT and I'm on a pre-med track, and I was just wondering, from a clinical standpoint, if somebody came into a hospital with an opioid addiction and they had a health condition that required the treatment with an opioid, how would you handle that, if I can ask that?
Yeah, so the question is, how do we treat patients who require opioids and also have an addiction issue? We give them opioids. So this isn't an anti-opioids. Opioids have an appropriate place in medical care. So we will utilize them. We see that a lot, actually, for people who have significant medical issues going on. We will use that while we have to, and then switch when we can. You're welcome. Uh-oh. Oh. Go ahead.
Hi, my name's Sophia. I'm from Appomattox High School. And you mentioned 12-year-olds and how they're starting really early. What are ways we can target those kids in that age, and how can we reduce that number?
Great question. So how can we target children who are at risk for using and reduce the number that do use? So I think that one of my dreams for Christiana, and one of the things I was just advocating for in a high-level meeting yesterday, was that we need to get more involved in prevention in the schools. And so that's one way, is to be really present, to be honest and have real conversations and not treat it like a taboo subject. So I think that's one. The most important thing, honestly, is to treat the family system. Because the 12-year-olds usually that are using are coming from a broken family system. So if we do a better job of engaging with the family and helping the family as a whole, we have a better chance with the kids.
Hi, I'm a senior from Epidemic High School, and I remember you talking about how it's easy to get Narcan now, or it's easier. Is it over the counter?
Yeah, is it easy to get Narcan? You can go into the pharmacies and get them. Yep. Great question. Please get it if you think you need it.
Hi, I'm a senior at the University of Delaware, and I did my literature review last summer with Tim on neonatal abstinence syndrome. I was just wondering if Christiana Care had any research data on which effective treatment for MAPS at all, if there was.
So treatment effort for the treatment, sorry, I'm being phone called, for NAS babies. So yes, there is. I won't pretend to know it well, so I don't want to speak to it, but certainly we could get you that. There's a lot of research being done, absolutely.
One more question in the back.
Hi, I'm a junior at Middletown, and I was asking if you think Christiana Care would ever sponsor a nonprofit with kids with opioid addictions.
Would we ever sponsor a nonprofit for kids? I'm being recorded. I think that we are certainly open to looking at partnerships. We work really closely with a lot of different agencies and definitely have partnerships. So certainly it's I can't say yes for the system because I want to come to work tomorrow. But I can say we're pretty open, so certainly worth a conversation.
And I can fill in, not working for Christiana Care, that part of Christiana Care's community benefit program, the work that they do in the community, the work they do in collaboration with organizations like the Academy of Medicine, they do exactly what you're asking. Not just to one organization, though, but to scores, if not hundreds, of concerned organizations. Now, if a youth-focused group, perhaps even better, a youth-led group, were to start, would that be something that the Academy of Medicine might be interested in? Yes, we absolutely would. I can only speak for the Academy, not for the health system. But it takes all of us coming together to address this. One of the things that I didn't hear you talk about was the We Are Not Anonymous movement. It used to be Alcoholics Anonymous, Narcotics Anonymous. Now we're talking about it. I'm in recovery. I have been for years. It's really not a big deal. It was at the time. But we need to talk about it just as being people. It's something that happens. It can be horrible. It can also be managed.
Just to over here, Tri-Medical Society of Delaware, they also do nonprofit sponsorship for the youth community.
She's saying to try the Medical Society.